pretend not. Okay. Don't picky, please don't picky. All right, who says A? Who says B? Who says C? Who says D? Who says E? No, do not. All right, C's already into it. Good job. All right. 23-year-old female presents to clinic complaining of fatigue, bilateral ear pain, pharyngitis, and mild dysphagia. Her temperature is 100.2 and her main vital signs are within normal limits. She has a low TSH, an elevated free T4, and an elevated ESR. Which of the following is the correct process with the process of thyroiditis? So first you understand what you think it is. Guessing, hopefully. Makes sense. And then you can figure out what's the main malfunction with this thing. So yeah, the second one question. So take a moment. I had to give an E because I'm lazy. Don't be mad. All right, who says A? Who says B? Who says C? Who said D? Who didn't raise their effing hand? Everybody? Those say A is correct. Those says A is correct. And this is what I call the painful subacute thyroiditis. All right. Painful subacute thyroiditis. Good job. I was going to say it's a virus infection. So, gee whiz. What would be the one patient's erythema and fluctuations of the thyroid? And then the temperature would probably be way higher. Which one would that would be? Separative. Very good. Infectious separative. I put both verbs on, that's fine. Okay, good. All right. Which is the most common etiology for primary hypothyroidism in the United States? The reason I ask you most common shit, because that's some of the stuff you're going to see. It's only Monday and we're cruising already. I'm so sorry, guys. That's going to be the stuff you're going to see, so that's, of course, very testable object. So, all right, most common. All right, who says A? Who says B? Who says C? Who says D? Who says E? Ah, good job, guys. Awesome job. Good job. Yeah, so autoimmune. All right, which of the following laboratory tests can diagnose primary hyperthyroidism? So first you figure out where the malfunction is. I think it's primary. I'll give it 2 labs that go with that. So, all right, who says A? Who says B? Who says C? Who says D? Who says E? Who says smart? Good job. He's right. So that's basically a question I ask you. The one-liners, that gives you more time. Easy peasy, pick them on out, and gives you more time to look at the vignette ones, which it's bad, but yeah. So primary is going to be the only thing you're going to say. You're going to write to me later on Facebook or whatever, Instagram, like, be like, I saw secondary hypothyroidism. No. All right, let's see, this gives time to read this shit. Sorry. A 52-year-old female presents to your office for follow-up on her newly diagnosed hypothyroidism. 6 weeks ago, she prescribed levothyroxine, also Synthroid, after thyroid stimulant hormone was found to be elevated. She was taking medication as instructed. Her symptoms are somewhat better, but retesting her thyroid stimulant hormone shows that it is still elevated. Which of the following is the next best step in her management? So somewhat better doesn't mean all better. Makes sense? All right, who says A? You better not, I'll kick your ass. It's the devil. Who says B? Who says C? Who says D? And is there not an E? Good job. C's right there. So the reason why it's somewhat better by her TSH is improved. So again, I wasn't perfect. Now, in real life, if you have an elevated TSH, but I'm like, I feel amazing, I've lost this weight, I'm not like, whatever else, like, weight loss is a common symptom for females especially, but she's feeling great. My bowel movements are normal, I'm not cold all the time, weight's gone, my TSH is a little bit elevated. You don't have to go up on that, just go back, maintain the current dose of levothyroxine, repeat the TSH testing in 6 weeks and see how she's doing. But somewhat better, but not always better. That's the problem. And my TSH is elevated, so I get my two things to treat this patient. Make sense? Yeah. Don't pick A. I'm gonna kill you and you. All right. All right. Which of the following would indicate a sign or symptom of hypothyroidism? I'm sorry, hyperthyroidism. Just kidding. I can't read. Sign or symptom of hyperthyroidism. Remember, so which way is the metabolic amount going? Crazy elevated, right? Crazy elevated hyperthyroidism, right? So picture what goes with that. Okay. Okay. All right. Who says A? Who says B? Who says C? Who says D? Who says E? You guys are so smart. Good job. You're so strong. Happy hands. Good job. That's right. I changed the slide a little bit, so sorry. I used to have them all one slide and not change it. So. Which is the most common thyroid cancer? Easy peasy. Most common. What do I ask you? Okay. All right, who says A? Who says B? Who says C? Who says D? Awesome, good job. Those who raise your hand, good job. Papillary is most common. All right, any questions on that? All right, so this we're going to spend 2 days on this lesson, right? And then we'll start probably with Addison's tomorrow, next time I see you guys. And then we'll talk about Wednesday, whatever. You can stretch them out, phone, whatever. So, talk about. All right, so moving down the line, right? So, again, we're going to talk mostly about like Cushing syndrome a lot. You understand, like I said, Cushing syndrome is a big umbrella. There's Cushing disease under there, and then don't, right? I like that phrase. And then Cushing syndrome, it could be it's coming from the adrenal glands or it coming from somewhere else. The other places where it's interesting, so the ectopic cortisoid. So we're going to go over some of these things as a refresher, whatever, she got better. You can read the slide on your own. But again, now she's better. Yay, look at her, yay. She's not better. It wouldn't be that quickly, but yeah, so she actually had, according to her book, adenoma. She had Cushing disease, right, in the dome. That's no problem. All right, so just a quick review of what the adrenal glands do, right? So all we're talking about is the outer portion, not the inner portion. We'll talk about the inner portion on Wednesday, at least beginning talking about it on Wednesday. So we're talking up here is this stuff. This is what we're talking about. So we also talk about this bad boy. This is regulated by ACTH, as you know. You guys know this very well, I'm sure you do. And this is regulated by the RAS system. So again, completely different regulation. So sometimes, every once in a while, if you have, for example, an adrenal adenoma, the only thing happening with that is secreting excess cortisol. Other times, they have, especially if you like hyperplasia, you get an increase in both your aldosterone and in your cortisol. So they're having like a multitude of different effects. So just kind of to keep that in mind. So aldosterone's up here, and the cortisol and androgen we're talking about is down here. So medulla, we're going to say that for Wednesday. We talk about adrenal medulla and MEN syndromes. All right. All right, so this is what we're talking about. For more prolonged stress, like everybody in the same classroom feels right now, all the time, what's going to happen in this case? It's not the acute stressors, like not the fight or flight stuff. That's what the medulla does, MU and NRB. This is more prolonged stressors, and depends on, how the patient regulates this issue. So CRH is released from the hypothalamus. I don't care about it. What intense releases your ACTH. What that's going to do is go downstream and release your cortisol, an excess of cortisol, which is actually beneficial for a lot of people. It's beneficial for temporary reasons. You can imagine, if I had adrenal adenoma, too much cortisol being secreted, that's a problem, right? I'm having excess of this and I don't need it. And so ACTH is here. So you get mineralocorticoids, that's your aldosterone, and you get glucocorticoids, that's your cortisol. right? So I get a double whammy. That's weird. A double whammy that's going to happen. Any questions or concerns in this? I know it's like a refresher from AMP2, not near as cool as what Dr. Walters uses it, but I do the best I can. All right. So understand, you just got two features: mineralocorticoids, glucocorticoids. Mineralocorticoids is aldosterone, glucocorticoids is cortisol. Cool, good job. All right, so again, one huge thing to think about with glucocorticoids is the effect for influence on glucose metabolism. That's a huge thing, and all the negative stuff that's going to happen with that is a huge result of its effect on glucose metabolism. And so again, if I have an effect on glucose metabolism, long term, I have too much glucocorticoids, I'm going to get fatter, and my cholesterol is going to be increased. That's two big things that can happen if I get too much glucocorticoids. Mineralocorticoids, let's talk about that. It regulates potassium balance, what it's supposed to do, and aldosterone. And then the androgen, we're going to save that for the end. We'll talk about it tomorrow at the end. We talk about a CAH is basically, well, you see an effect on that. So again, we'll talk about, it's a congenital condition, so you're born with that. So we'll talk about what that looks like tomorrow. Right, so the norepi, we talk about that, that's fight or flight. That's instant, quick response, very quickly, what it's supposed to do. We'll talk about that one on Wednesday. So again, hypothalamus releasing CRH, nobody cares, but anterior pituitary releases ACTH. So in effect, what's supposed to happen if I make, when I have too much cortisol, what's supposed to happen naturally to my ACTH? We're making too much cortisol. Exactly. It should go down. Exactly, go down. If I not making enough, I'm making way too much cortisol. I'm sorry, not enough cortisol, words. Not enough cortisol. What's my ACTH supposed to do as a response? Yeah, kick it up. Exactly. So understanding that basic pathway helps you understand when it all goes wrong. Okay. All right. It's released, well, hypothalamus, I don't care. It is also diurnal. Diurnal means, diurnal is true for CRH, ACTH, and cortisol. They're all true. They're all diurnal hormones. What the hell do I mean by diurnal? What's that? Yeah, so higher during the day and plummets at night. That's a natural thing to happen. It does not matter if you work in the graveyard shift at all, or if you're working, a night shift. So we're working, I don't care. It doesn't matter. It's just higher in the morning and lower in the middle of the day. So I'm going to skip the CRHs because I don't really care about those. Right? I care about ACTH and cortisol. Yeah, that matters. So ACTH will produce an anterior pituitary. Hope that makes sense. We talked about the anterior pituitary implication. And now I'm telling you about when it actually gets released. When it actually happens. So secreted in the pulse is a diurnal rhythm. So it's highest in the early morning, like before I want to get up, and lowest at night. That's what diurnal means, right? So keep in mind, growth hormone. How is growth hormone released from the anterior pituitary? Exactly, like 8 to 12 pulses per day. That is not diurnal. Note to self. Okay, so highest in early morning, lowest at night. So especially if you ever had a little one who has a fever, or if you had a fever yourself, poor guys, when is the fever going to be typically at the worst? It's always at night. Reason why? ACTH goes down, by default cortisol goes down, the same effect. And so it's worse at night because that's your natural inflammatory response is suppressed then. So, talked about that already. Like I said, RAS also works on this as well. So it gets not only affected by ACTH, also affected by the RAS system. So I cut out a lot of this part of this lecture, meaning we'll explain it more tomorrow, but I cut out a lot of different reasons. You don't have to say RAS with me at all because it's not an endocrine thing. When you study your butt off as far as some of the primary hyperaldosteronism, that'll when you know, but that's it. That's the only endo thing. I took out everything else. So this is really important. It also stimulates melanocytes to produce melanin. So what would be effective for producing a lot of melanin everywhere? What's that? Get darker, exactly. So anybody happen to know what are the effects if you're getting darker everywhere? Nice hand, good job. Nice hand. But what endocrine condition would I be having if I was getting darker everywhere? Addison's, exactly, because guess what? I have way too much ACTH. It's trying to kick cortisol into gear, right? Get it going, because it's abysmal. Cortisol levels are non-existent, right? That's not happening. But because I have so much ACTH, it's kicking out into alpha MHS, melanocyte stimulating hormone, and I go buck wild, get all burning and crazy. Oh, wrong one. So it's inhibited by cortisol via negative feedback, right? So I have too much cortisol. What's supposed to happen to my ACTH? Actually diminishing, and then same thing if I have not enough, it's going to be going back. So now again, the major glucocorticoid distributed by the adrenal cortex is cortisol, by far and away. So again, secreted in a diurnal pattern. Highest in the morning, lowest at night. It kind of matches ACTH. Highest in the morning, lowest at night. That mirrors that. Makes sense. CRH does it too, but I ignore the hypothalamus. Nobody cares. So increased secretion occurs in the settings of this. So exercise, as a good valuable thing. Acute trauma, right? So I don't care if I got a motor vehicle accident or like people have had like a terrible pneumonia or stuff like that. Cortisol being secreted as a good reason to kind of get you over this particular thing. That's a normal cause for this to happen. And of course, stress, all you poor little iPad kiddos, stressors, that's gonna bug you. So, so some people notice they don't, they think they have like Cushing syndrome. They don't have it, but just you have an increase in your cortisol response because of stressors and like 16 months of stress, and then 11 months after that. So, anyway, so highest in the morning, lowest at night, right? So again, if I have 22 as my ACTH or 12, that's a lot more than like 1 to 3. That's a huge, huge difference. So again, highest in the morning, lowest at night, that's what diurnal means. So again, this kind of messy one, but so the red one is what your ACTH looks like, and then the green one is what your cortisol looks like. So that's just like, no kidding, it mirrors each other, right? Because if I kick up my ACTH, by default, what's going to happen downstream, my cortisol can bump up. So that's a continuous thing that's going to happen as a response for that. And again, this is when I'm thinking about, was it the highest? Boom. Early in the effing morning. Good job. Okay. Any concerns about that so far? Okay. Hopefully short but sweet refresher. All right. So you think about what happens to your metabolism. So it changes the way you metabolize carbs, the way you metabolize fat, and the way you metabolize protein. So it goes everywhere. It goes everywhere. And especially think about this, carbohydrates is huge, right? Carbohydrates meaning like sugar, that's a huge thing, which is why a lot of your patients who say they have Cushing syndrome, they're also almost either pre-diabetic or actually outright diabetic because of their increase in their obesity. But these are all some of the examples of all this. I'm going to read the whole thing to you, but make sure if you go back and like, why does this happen? Go back to this slide and say like, okay, this is why this happens in particular. So yes, yes.
On the chart, it shows that cortisol generally spikes around mealtime. If it's inhibiting insulin secretion, it seems kind of counterintuitive.
It does, because if I have an excess of cortisol, right, like such, this is like excess cortisol, but it spikes during meal times, which is a good thing. Normally it's supposed to happen, but again, if I have too much cortisol happening, then basically I'm inhibit my insulin secretion. So one, what happens if I'm not getting enough insulin? What happens to my blood sugar? It's gonna go up, exactly. So I got the good thing, yeah, exactly. Make sense? This is what it normally does. It does spike up during meal time, so this other chart. So like, lunch here, boop, spikes up. Dinner here, spikes up. Snacks here, a little bit spiky. Breakfast, crazy high. But that's a normal daily basis for all you healthy individuals. But if I have too much cortisol and too much ACTH, what's going to happen? I end up in hyperglycemia because of this. Inhibits insulin secretion and also inhibits glucose uptake by the muscles and fat. So that's a buzzkill. So I'm not making enough insulin, and then, oh, by the way, I increase the glucose uptake by muscle and fat, and you're in a elevated blood glucose level.
So that's just going to gradually kind of goes back to level versus...
Yeah, exactly, because it's like, look at that, I come back down to normal. I think just every healthy individual in this classroom comes back to normal. But this happens during meals, which is why some people with intermittent fasting do very well with that, because I don't eat, and then eat this, and then I'm done. So for some people, that seems to work very well as far as weight loss. Make sense? But keep in mind, not your blood sugar is not the only thing going up. Your cholesterol is absolutely going up as well. So it's like a double whammy. All right. So now I talk about excess cortisol. So inflammation is suppressed. Normally, a normal human being, inflammation, the immune system being suppressed, that's usually a very good thing. What would be an example of, if I just said a normal human being, wouldn't that be a good thing for a patient to have? Like, my immune system is suppressed. Wouldn't that be a good thing to happen? What's that? Why would he be overactive? Can you know that? Yeah, allergic response is good. Inflammation is suppressed. That's exactly, allergic response is a good thing. Another reason is if I, for example, got new lungs, or a new liver, or a new brain, any new brain. But that's a joke. Yeah, so if you're basically on a transplant list and you got the transplant, good job, you have to take steroids for the rest of your effing life, forever and ever. The reason why, because inflammation is suppressed and your immune system is suppressed, because otherwise you will counteract that organ and you're going to sadly die. So they figured out all the benefits that cortisol does and to kind of keep them on a long term. But again, this is way back when, because my story, but my dad was, he smoked, but he quit smoking at 40. He developed asthma at a weird age, and they developed COPD, because it mirrors the same thing, basically the same thing. So he developed COPD, and so way back then, all he had was Kaiser. They still have that damn system. So all he had was Kaiser, so like the cheapest, lowest money possible. So he was taking oral steroids on a daily basis to control his asthma attacks, because inflammation is suppressed, right? His lungs, the bronchoconstriction, whatever, of asthma, and also his COPD, which is forever, was suppressed. But again, I literally watched my dad turn into a Cushing's syndrome person very quickly. So now he's lost all the weight, he's doing great, but because now we have better drugs to treat that, inhaled drugs are way less systemic than oral pills. He was taking oral pills, he had to take gall, the fire department, like once a week to take him to the hospital and stuff like that. It was crazy. But anyway, so this is what happens. Inflammation suppressed, immune system also suppressed. So another thing, if I have too much cortisol, what's going to happen is it suppresses the bony formation and it decreases the calcium absorption of the bones. So what would you get as a result of that? Exactly, osteopenia, osteoporosis, either one. So long as the patient has this effect because of too much cortisol, that's going to happen. Weight gain, of course, I should put that at the top, right? Weight gain, particularly truncal obesity. Some of these slides are exact mirror from what we talked about in lesson 3, because it said Cushing syndrome and Cushing disease look exactly the same. It's up to you guys to figure out which one it is. But weight gain, particularly truncal obesity, right? So oftentimes they'll have, a giant looking like beer belly, but they have like skinny arms and legs. That's a huge difference from how normal, a lot of people who get obesity, they're kind of chubby everywhere. Maybe it's more in the belly, but they're chubby in my arms, in my legs, in my butt, everywhere. But again, just keep that in mind. Particular truncal obesity is a huge thing. So another slide on this as far as what excess cortisol. It changes how you break everything down. It's a huge effect. So loss of connective tissue, thin skin. We talked about this in lesson 3 as well, but this is why if I nick my leg shaving, it just will not heal. It takes like 3 times that length of time. Also develop bruising. Bruising everywhere. I didn't burn anything, but I'm bruised everywhere. We often think about like, anemia being one of the effects. This can happen if you have too much cortisol. Check with that. So sodium water retention, right? So again, you have too much blood sugar, right? Hyperglycemia. You have way too much, your cholesterol through the roof. And then, by the way, I am also retaining my sodium in water. So I'm not just like puffy, I'm actually literally puffy, swollen. If it happens in kiddos, the only time you typically see this is somebody who sadly needed kidney transplant or something like that, transplant stuff. They have excess cortisol. You rarely see Cushing syndrome in kiddos, for the most part that I know of. A lot of times you'll see it. But if they do get this, growth failure in kiddos could be a problem. So if you happen to see that. And of course, everything else changes. The mood, the behavior, the cognition is impaired. Again, it's often being more like depressed sounding than like to feel terrible. All right, any questions on what cortisol does? I can take that out if it's like too much like repetition from A and B2 or whatever, so let me know if I can take that out. All right, so Cushing syndrome. I want you to learn this also as hypercortisolism, because sometimes I might give you an exam question where I said the initial testing confirmed hypercortisolism, right? That means I did, what's the first test I do if I'm thinking the person has too much cortisol? Just a method suppression test, awesome sauce. Okay, and then what do I confirm that with? Yeah, ACTH and then the 24-hour urine test, exactly. The 24-hour urine cortisol and the ACTH is going to tell you where it's coming from. Exactly. So if I could give you an exam question saying you confirm this patient has hypercortisolism, I'm telling you did the first 2 tests. It makes sense? It confuse anybody. Right. So then I might ask you what's going to happen now. So just understand these 2 things are synonymous. So again, repetition. I like to repeat myself a lot. So remember, the umbrella. Disease from the dome. What's my malfunction if it's coming from a dome? Why do I have this issue? Too much ACTH. Very good. Exactly. Too much ACTH. And then syndrome. We could be coming from my adrenal gland, right? That's a big one. Or we could be ectopic. I'll give you some examples of the ectopic versions. Okay? All right, but they look the same. Now we're focusing on this bad boy because I'm talking about the adrenal gland, so that makes sense. All right. So a lot of times it is our fault. I 100% agree. It is our fault. Like I said, my poor died, went to Kaiser. It went to Kaiser. He was taking oral steroids for a long period of time for his asthma and the COPD. And so he developed Cushing syndrome. So our fault. Long-term, high-dose, exogenous, meaning I wasn't born with it, glucocorticoids. That's very, very common. Very, very common. So how would you find that out on your patient? Exactly, yes. Thank God, you ever, yay. Yeah, the history, exactly. So that's a huge one. So if I wrote in the question, patient denied taking any steroids or denies taking any glucocorticoids, right? I'm telling you, giving that information. So boom, I can cross this one off the list. That's not, I didn't do it to the patient, okay? The next one is a common one. It's actually acetate producing pituitary tumor. Cushing disease, we talked about in lesson 3. Cushing disease, that counts for about 68% of them. Then these are some of the other versions. Adrenal adenomas or carcinomas. Carcinomas often may kill you. Adenomas won't kill you, but you kind of want to die being obese. And then the other version, secretion of ATH by non-pituitary tumors. Non-pituitary tumors. So paraneoplastic syndrome, that sounds all fancy, that's all we're talking about. If I'm having something being secreted by something it shouldn't be secreted from, that's what a paraneoplastic syndrome is. We talked about this in lesson 2, talking about a small cell lung cancer can secrete ADH. Who knows why, but it does. So that is a paraneoplastic syndrome. Make sense? It is ectopic for sure, all day long. Exactly, and it's ectopic hyperfunction, so it's malfunction. All right. So these are some other examples of paraneoplastic syndrome. So it's stuff that's being secreted from someplace it shouldn't be secreted from. So one of those weird things, whoever figured this out, way smarter than me, occurring alongside the hormones, so excreted by the tumor cells. So one of the most common one, we talked about it with SIDH, but lungs, especially small cell lung cancer, again, secretes cortisol. Secretes cortisol. If you have small cell lung cancer, maybe a buzzkill, it's not going to do well. This is the most common one. There are some other ones too, but I just want you to know for this one, stay focused on the lungs. That's the most common version of this, is small cell lung cancer in this case. Any question what paraneoplastic syndrome is? Okay. All right, cool. Don't worry about that. I mean, it's kind of useful if you like looking at charts. I don't, but, okay. So hypercortisolism, also known as Cushing syndrome, they go together. After delay in diagnosis by 5 or more years. Again, I don't want you to delay diagnosis with acromegaly. Same with Cushing disease, the same as syndrome. And same with Cushing syndrome in overall. So again, don't be the person who's delaying the diagnosis saying like, you're just fat, lose some weight, get a job, I don't know, wherever they're saying. So don't be that BA. Average saw 4 clinicians and finally got to the right diagnosis. Be that clinician. Or maybe they're stuck with you and they only see you. Don't do that. All right. So we talked about the same exact list from Cushing disease because they looked exactly the same. Okay? So understand the signs and symptoms go together. They don't know, like I said, the most common signs and symptoms you're going to see is the beer belly for sure, the central obesity for sure, the purple striae, not like, oh, it's a little bit silvery, no, purple, or it could be deep dark red, kind of like, whatever the patient's skin tone kind of mirrors what the color of their stretch marks are. The buffalo hump, they still call it there. The plethora moon face, right? So moon face, I'm like red and my face is enlarged. The thin extremities with muscle atrophy, right? So I've got the giant beer belly, but I have the little scrawny arms and legs, especially proximal muscle weakness. So again, my biceps, my triceps, my quads, my hamstrings, and then this other stuff too. But so hopefully it makes sense. Yeah, this person looks like this. Now, going back to lesson 4, hypothyroidism is way more common than Cushing syndrome or Cushing disease. Way more common. So again, pretend the TSH lab costs $1. So I would order TSHs. I very rarely order a densitometry suppression test. I have for sure, and I've caught it. Yay! But I've been wrong a couple times too. Buzzkill. So, All right, anybody need me to go more time on this one? Same slide as before, sorry. Keep it refreshing. All right. All right, so what do you notice about this poor patient? Moon face, yes, for sure. What else do you notice? What's that? Hirsutism, exactly, hirsutism. We didn't even talk about it until block 2, but hirsutism is key with that. Why would I have hirsutism? Exactly, androgen also being secreted, right? So androgen being secreted, and so what else do you notice in this particular patient? What's that?
You see that she's got something.
Exactly, this is, you can't, this thing is not there, exactly. Yeah, I can't do it in this one, I can't. It doesn't work. But anyway, so they're not there. What else do you notice? Acne, absolutely. Acne for sure. And they often have like oily skin as well, which goes along with a lot of patients. You have hirsutism, it's a female. Hirsutism, have oily skin, also have acne. They all goes together. All goes together. Because again, if I'm making too much testosterone, again, I'm getting way ahead of myself. Next block of material. But if I had too much testosterone, then I'm sprouting hair where it should be sprouting hair. And then, but I'm also oil skin and acne, but I feel maybe a little bit more frisky. Good job. Whatever. That's also a joke, but I'm not very good at that joking. But yeah, that's bad news. So yeah, good job. Would you suspect this patient had any condition? If you saw her after picture, that's her after picture. Good job. Yeah, so she had Conn syndrome, unilateral adrenal tumor, aka Conn syndrome. That was her case. But again, you have to listen to the patient's history. This person not gained weight overnight, but it was more recent. It was more recent than, she hasn't always been obese. But this is post-operative. 3 years later, her one adrenal gland needs steroids to wake it up, but that's her, now she's all better. So in this case, Conn syndrome is basically one subtype of adrenal adenoma. You can take one adrenal gland out, and then there's another one still working very well. Good job. What do you notice about this guy? Striae for sure, exactly. I told you striae, exactly. What else do you notice? Truncal obesity, exactly. Moon faces for sure. Exactly, but so that's when like you don't want to judge this person saying like, you're bullshit. What else do you know about his arms? You can't see his legs, but
Small.
exactly. That's like compared to what this is looking like, his arms and legs are fairly skinny. But his face is big, so that's a huge thing. And then you mentioned it over here, but supraclavicular fat pads are gone. So if you turn to the side, you probably notice he definitely had a buffalo hump. He didn't turn to the side, so we don't get that, but make sense? So this guy, his story, Tony's story, he had fast weight gain. He tried every night, with no success. He had large stretch marks, acne breakouts on the back, his chest, mood swings, and issues of anger outbursts. I can imagine. I'm angry too. Weakness in the muscles, ankles that would dislocate all the time and bruise badly, cracked and broken ribs from doing hardly anything, and the list goes on and on. So his story is kind of wacky, but this is his before and after. Like, can you imagine the guy on the left, this is the same guy, the guy on the right, yeah. And you can kind of tell this little buffalo hump there, a little bit. But so his story, I don't think I can give the stuff. So his Cushing syndrome, so his cortisol was elevated, his HH was elevated. Repeated labs and also, oh, my Siri's talking to me, it's weird. Repeated labs and confirmed MRI of the brain was negative. CT of the abdomen was negative. I'm like, why didn't you look elsewhere? But that's really weird, but I'm not an endocrinologist. Was told there was Cushing disease, which where is Cushing disease? Right in the dome, I remember saying that's kind of cute. In the dome, could be very small. So he had the IPSS, some of the petrol sinus sampling. Venous blood from pituitary, which hurt a lot. He has a cool story on the list I post at ENDO tomorrow. There's a cool, you can read a lot about Cushing's syndrome or Cushing disease, etc. It's really cool. But he was awake for that procedure. I'm like, ooh, some people. So finally, he had an MRI of the chest, abdomen, pelvis, and PET scan. They're basically like, we're just going to work you all up because we were wrong with our diagnosis. Finally found a lung tumor. So his was an ectopic version of the cortisol happening. But again, listen to your patient. You're the patient on the left-hand side. Do not just think he's fucking lazy and a POS. He's not lazy, and like, you figured it out. So we'll talk about how to go about figuring this out. Typically, if both levels are elevated, for example, my cortisol is elevated and then my ACTH is elevated, I'll give you a vast difference in what it should be if you have Cushing disease, where it's coming from the dome, and ectopic coming from the lungs. That's what his case was. So, makes sense? All right, crickets, good job. All right, so keep in mind that I kind of told the story because the testing can be somewhat confusing, and his too. They were like, I know it's disease. I still think it's disease. And we're like, go there and sample it, and like they were wrong. You know, the endocrinologist and the surgeon were wrong. Okay. But so these characteristics of Cushing should be all present. I mean, again, they all should make decent sense. Lack of cortisol diurnal variation. So meaning, what I'm saying is high all the time. High all the time, right? And I tell you how to go about measuring it when we talk about the dexamethasone special test, and that's a repeat lesson. Again, we'll talk about it again. Reduce suppressibility of cortisol by dexamethasone. That has to be one of the features you're going to have. If my cortisol level was maybe a little bit elevated, it should go down with dexamethasone. I check it again, boom, it should be done. Because whether it's happening naturally, cortisol, or if I'm taking the pill, dexamethasone, it does not matter where it's coming from. Your body recognizes that you have enough cortisol. That should happen. An increased cortisol production rate. And then suppression of plasma ACTH. When I give you dexamethasone suppression test, what should happen? By default, my CH should go down. I don't care about that. My ACTH should go down. And by default, my cortisol should all go down. And that didn't happen. And then convincing results are common, which is why I added Tony's story in there. It's kind of interesting. There's a lot more to his story, but it's very interesting. He finally got relief. Okay. So just kind of refresh again, just put the same slides in. If you remember, if you take a steroid, and we learned the exact dose for dexamethasone, what we do, I know exactly what time I give it to them, but you could do any steroid. But I give them the steroid 11 o'clock at night, take this pill, boom. You have their blood drawn the next morning, your cortisol drawn the next morning at 8 a.m. Okay, it has to be very specific at those times, okay? So what should happen is you would make less cortisol. Not gone cortisol, but less cortisol, right? You see, look, go down. All right, so if you have Cushing disease or syndrome, it kind of depends on where it's coming from. When you take a steroid, which is dexamethasone, what should happen didn't happen, right? We have either the pituitary makes less ACTH by negative feedback, that should happen. If it's Cushing disease, that didn't happen either. By default, they should make less cortisol, but some of your disease or syndrome has more cortisol. So getting the ACTH will help you determine where it's coming from, okay? So now this one, now we're talking about this one, Cushing syndrome. Pituitary takes more or less ACTH, we'll define exactly where that is. And so of course, by default, they're going to still make more cortisol. Yes, sir?
For the dexamethasone suppression test, when we take our cortisol levels initially, it doesn't matter what time we're taking them initially before we can dexamethasone.
You don't have to check it before at all. You don't have to check it before at all. You just, you look at the patient, you're like, I think I have Cushing syndrome. semi-test. You don't have to check it before at all. What you're gonna see though is normally what you're gonna see is suppressed level, like nibbles like abysmal gone. Yeah.
So
That's what it should be.
lower than normal, not lower than normal.
Yeah, exactly. Just lower than normal. That's the first time I checked cortisol on this patient. First time I checked it. Good question. Oh, sorry. Okay. All right, so same stuff we did before. We'll talk about this. So the very first test you do, if you're suspecting this person has either syndrome or disease, I'm going to do a dexamethasone suppression test. I give them dexamethasone. Oh, this amount. 1 milligram, easy. I eliminate it at 11 o'clock at night, and then I measure the cortisol the next morning and see what happens. If any level is elevated for that, boom. What's the next test you're going to do? Yeah, exactly. 24-hour urine, cortisol, and ACTH. 24-hour urine, cortisol. Because all what I'm saying is I suspect I have hypercortisolism. That's my initial test. If I have too much cortisol, where the hell is it coming from? To confirm it, the 24-hour urine test, which is a giant pain in the ass, and then the ACTH. Okay, so urine test, ACTH, boom, to confirm that. Make sense? Did I lose anybody so far? Crickets, man. Okay. So now to figure out who to blame. Don't get confused. Don't get confused. Alright, so third ACTH after the hypercortisolism is confirmed, right? I confirmed it's too much cortisol, boom. I figure where it's coming from. ACTH is so important because that's going to tell you exactly where it's coming from. Exactly where it's coming from. So that differentiates between ACTH dependent. All that means is I'm making ACTH. I'm secreting ACTH. Or independent means I'm not secreting ACTH. Does it make sense? I didn't invent those terms, I promise. I didn't write the books in ENDO. Dependent just means I'm secreting ACTH, and I shouldn't be, right? By default, I should not be secreting ACTH. Or independent, I'm not secreting ACTH. That's what those two terms mean, okay? That confusing me so far. Alright, so ACTH dependent, meaning I have high cortisol, confirmed it, money, and I have high ACTH. Because of both those things, that's what dependent means, okay? So, these guys with elevated ACTH. For example, Cushing's disease. Like, no shit, it's coming from a pituitary. That's the reason why it's elevated. Or, if it's insanely elevated, that is an ectopic source. The one I want you to remember is small cell lung cancer. Carcinoma can also do this, but if my level, let's say 2 to 4 times the upper limit of normal. When I say upper limit of normal, what do I mean? Remember, for every lab has a normal range. Let's pretend a normal range is 1 to 10. Exactly. So look at the high number, whatever the highest range is. If it's 10 times the upper limit of normal, 10 times 10, that would be somebody's ectopic. If I have, let's say my number is 20, right? Is that 10 times the upper limit of normal? No, but it's a little elevated. So these Cushing's disease, normal or moderately elevated 2 to 4 times the upper limit of normal. So remember what that number is, the normal range, multiply that. Or if I have 10 or more times the upper limit of normal, that's insanely elevated because once again, that was a perineoplastic syndrome. That's why it's so insanely elevated because it shouldn't have been elevated in the first place. So understand those two causes for that. So if I suspected, for example, if I suspected Cushing's disease, my number matched with Cushing's disease, what imaging study would I get on this patient? MRI of the brain. Exactly, MRI of the brain. Pituitary. So if I suspected that this person has 10 times the upper limit of normal ACTH, crazy, insanely effing elevated, and cortisol, hypercortisolism. Both things are crazy elevated. What study would I do in this patient? Exactly, CT of the chest and the belly, because carcinoid can be a feature of the belly. So just remember, chest and belly, CT, the crap out of it. You could also do MRIs, but oftentimes CT is a lot more indicated, it's a lot faster. Radiation, that sucks, but CT.
I was just gonna ask what I would consider MRI, maybe it's just quicker.
Yeah, if quicker, cheaper, less historical life. Yeah, so this Tony had an MRI of his everything, so he went through that, but probably because he's been through enough stuff, I don't know. So we're gonna go over this again, but these are two causes of dependent, meaning I have high cortisol, right? We confirm hypercortisolism, and I have a high ACTH. High ACTH. A little bit high, Cushing disease. Crazy amount high, small cell lung cancer. Don't even remember carcinoid, just small cell lung cancer. Yeah, good job. All right. Any question on that before we talk about independent after the break? Cool. Two different conditions. So one, I give this guy cortisol, right? Both of them. I gave him cortisol, so by default, it should be like 5 or 6 or something abysmal. Very low. That's what happened to a normal human being. So the first thing I got is my common cortisol level to be elevated, right? It's an elevated number. It's outside the normal range. And I confirmed it with the urine testing. That makes sense? Okay. So then, I'm going to check the ACTH level in this person. So, in this particular case, I didn't hit more ranges because I don't remember what normal ranges are for ACTH and it kind of changes. So, I gave the ACTH of 75. So is that dependent or is it independent? Dependent. All it means is I have ACTH, but it shouldn't be there. I have ACTH, it shouldn't be there. So is that number 2 to 4 times upper limit of normal? Or is that, like, it'd be normal up to 2 to 4 times upper normal. So anything that's dependent, it shouldn't be there. So again, this number, this 75 of that person, what condition do you think that person has? Cushing disease. Cushing disease. Come from my dome. Exactly. Does that make sense what we got there? So remember, I can look at this 60. You only got to do the math. I multiply that number either anything between, even if it's nothing, that number at ACTH should be suppressed. It should be like 5 or like non-existent, gone. The fact of normal or up to 2 to 4 times the upper limit normal, which means up to 4 times number 60, I can't do math anymore, whatever that number is, 240, something like that. That's the thing. So in this person, I got the same test. His level is 48. I confirmed it with a 25 urine-free cortisol. Yay, I confirmed it. And I got his ACTH. Is that number insanely elevated or not?
Yes.
Exactly. 10 times this number. 10 or more times that number. That's the only math you have to do in my exam. That's it. You can do a calculator if you want to. That's cool. I can't do it either. But all I'm saying is it's greater than 10 times that number. That's the problem. Does it make sense? So where would that most likely be coming from?
Cancer.
Ectopic. Most common cause for that? Small cell lung cancer. Not squamous cell, linear, like small cell. You talk about oat cell. Exactly. Does that make sense what we got there? Cool. We'll see. Alright. I like teaching this, but like this one would get like confused. Like not you guys, me. Alright. Okay. So that's what I mean by upper limit of normal, okay? Alright. Yes. Please.
It's like the 24-hour urinary free cortisol.
Yeah.
So it's like above 50 per day. It doesn't have to be like.
Do not worry about what it looks like. I'll just tell you it's elevated. He's having a 24 urine test, free cortisol. I'll just tell you it's elevated, or you confirm the elevation. Yeah, you don't worry about that at all. That 50 is, it doesn't matter. Yeah, good call. All right. Does that make sense how we got here? Hopefully, maybe. Okay. So then we get to, oh wait, okay, what is this? Ectopic. I didn't figure it out because they're idiots. But okay, so independent causes. Independent causes. I know I have high cortisol. I have independent cause, meaning I don't have ACTH being secreted. That's actually supposed to happen in everybody in this room. If you have too much cortisol, you should not be making ACTH at all. So this would be one of the causes. These people have suppressed ACTH. So one of the most common findings for this is, ask the patient what medications they're taking, right? Because I'm taking steroids all the time, prednisone, dexamethasone, picazone, whatever it is. I'm taking these steroids all the time. My ACTH level should be abysmal, gone, because it doesn't know if it came from your body or it came from a pill. Doesn't matter. The ACTH is a massive amount of stuff, so it suppresses, and that should happen. So all you do is ask the patient, are you taking any steroids, right? Or glucocorticoids, pick your choice. So exogenous glucocorticoid use, patient history, got that. So you can narrow down exactly where it's coming from. If I know of hypercortisolism, I confirmed it. I know I have too much cortisol, and when I check my ACTH level, it's suppressed. Boom, I narrow it down to adrenal adenoma or hyperplasia. That's it. Carcinoma can also happen as far as adrenal carcinoma, but I know exactly where it's coming from. Does that make sense, how we got there? So, CT of the adrenal glands confirms there any one of these causes. Whether I get hyperplasia, that's bilateral hyperplasia, or I have a unilateral adenoma, or God forbid carcinoma, which often kills them quickly. CT of the adrenal glands confirms either. Notice I'm seeing CT of the belly or chest if I'm, we talked about that as far as ectopic versions, or CT of adrenal glands if I have this. So the only one I'm doing the MRI in is the brain. The only one I'm doing the MRI in is the brain. Mostly because think about pituitary is super tiny, so that's the reason why I do the MRI of the brain. Everything else pretty much is a CT scan. It makes sense? Not confuse you guys with like words, but okay. So I put it in another chart too. It's like very repetitive. So ACTH dependent, Cushing disease being a very, very common form of that. I would have a normal or 2 to 4 times the upper limit of normal, right? Or flip side, it could be an ectopic secretion, significant ACTH greater than 10 times the upper limit of normal, just like we just spoke about after the break. Or I could have, I confirm hypercortisolism, and I check my ACTH, and it's non-existent. That's what I mean. Non-existent means independent. Non-existent means independent. So atogenic, most common one. We did it to our patients. So ask them a great history. Or like I said, adrenal adenoma or carcinoma, and then bilateral adrenal hyperplasia. They look the same either way. The only thing it's going to tell you, I look at the CAT scan of adrenal glands, and it's very, very thin slices, and then I'll determine what the malfunction is. Is it hyperplasia? Is it an adenoma? Etc. So again, it's very low. That's what independent means. And this one is dependent. It's a little bit high or crazy effing high. To confuse you guys. Okay. I like pictures. Yay! So this is A is what a normal human being does. Good job. You guys are all A. I believe you're all A. You look like you're all A. Alright. I'm also upset Cushing's up. So what condition would you guess that B is? Where is that? That's pituitary up there. What condition do you think that is? Cushing disease, exactly. Awesome, right? So I'm making too much ACTH, so I'm making too much cortisol because the adrenal gland is just a dumb thing. It's doing what it's told. And this is a little circle over here. What about this feature? What is this bad boy most likely cause for this to happen? I'm making ACTH, but it's not supposed to be there. Ectopic, exactly. 10 times the upper limit of normal. Crazy effing elevated ACTH. So adrenal glands is doing its toll, kicks out way too much. My pituitary is making no ACTH, but you cannot determine pituitary ACTH versus ectopic ACTH. It looks exactly the same, so you can't determine that. But again, so here's this being secreted from here, ectopic version, small cell lung cancer or carcinoid, and that's a problem. In this one, I'm secreting way too much cortisol, but what did my ACH do? Exactly, it's just independent, exactly. So it's like non-existent, exactly. It's doing what it should do. But unfortunately, I have an adrenal adenoma or hyperplasia, and this one looks like an adenoma, and that's what my malfunction is. Does that make sense? Oh, weird. Oh, good. So weird graph I did last semester. Okay, so again, basic stuff. I suspect I have a hypercortisolism. So one, the first thing you need to figure out is you need to learn the signs and symptoms of hypercortisolism. What are some of the signs and symptoms of hypercortisolism? Exactly. Striae. What's that? Moon face. Hirsutism. Yeah, good girl. Oh my god. Acne. I like it. What am I missing here? Central obesity, yes, that's got to happen. You have to have that. Because I wouldn't get the star if I didn't have central obesity. Yeah, so I think this person has hypercortisolism. So first thing you do is you start here. So if I suspect hypercortisolism, I go from here. What's the first test you're going to do if you suspect this person is making way too much cortisol? Desmosome suppression test. Good call. So it's elevated. Good job. You're on the right track. What do you confirm it with? Everything trust but verify? Every lab in ENDO, trust but verify. So what do you confirm the test with? Exactly. 24 urine-free cortisol. Exactly. But it's very specific thing you're going to look for. And then what other tests I'm going to do along the same time? ACTH, exactly, because that's going to help you figure out where is it coming from. So 12 urine-free cortisol, next lab test, we got ACTH, good job. So we know the initial test you have to do, and I know the follow-up confirmatory test is the free cortisol, and then the next lab test is the ACTH. You can order at the same time, I don't care. But remember, 24-hour urine test is, that's a beast you have to do. I almost always do this on Sundays, so that way the patient's at home, collecting their pee and putting it in the fridge, good times, instead of putting it in the work fridge. Because that's going to the fridge. Alright, so last subtest is ACTH. So ACTH is mild to moderately elevated. What condition do you think that might be? Disease, exactly, Cushing disease. Pituitary secreting adenoma, secreting ACTH. If my ACTH is very effing elevated, what condition do you think that might be? Okay, small cell lung cancer, carcinoid, don't remember, but just small cell lung cancer, awesome. Alright? If my ACTH is not elevated, what could that possibly be?
Adrenal hyperplasia?
Adrenal hyperplasia or adrenal adenoma. Very good. So again, if you did all those tests and it really tells you exactly where it's coming from. Just those confirmatory tests. So what imaging would I do in this patient who I suspected he has Cushing disease? MR of the brain, exactly, pituitary, but yeah, same thing. All right, makes sense? So again, very thin slice. Okay, if I thought my ACTH was extremely elevated, crazy elevated, what imaging would I do? Exactly, chest and belly CT. Chest and belly CT. And then my ACTH is not elevated, so I confirm I have too much cortisol. I'm not making any ACTH at all. Who cares about that? So what imaging would I do in this particular person? CT, the adrenal glands, awesome. And it's often thin sliced, you're not quizzing it at all, but just understand, adrenal glands are not that big, usually. And so you do a thin slice if you're indicated for adrenal CT. So, brain MRI, chest CT, abdomen, it's CT and adrenals. Does that make sense? My weird ghetto-ass drawing. Hope it works. Alright, so don't worry about so much differentials. I love differentials because if you're wrong, what else does the patient potentially have? So these are some of the causes. Let's get that slide. So it's kind of busy slide, don't forgive me. So if I'm taking way too many steroids, right, you should know that just based on history. But if the patient's taking way too many steroids, I try to reduce the dose if at all possible. So maybe that 50 prednisone, maybe give them 20, but you got to do it kind of slowly. Reduce the dose if possible. A lot of times with transplants, it's not possible. You cannot reduce the dose. They're going to be 100% Cushing's patients. That's what it is. So we talked about this. ACT is producing pituitary adenoma, also known as Cushing disease. What are you going to do for that? Surgery. Yeah, exactly. Shove out a plano surgery. Good job. So adrenal adenoma or adrenal cancer, we're basically going to surgery to remove the mass, whether an adenoma or carcinoma, either version, we gotta take it out. Sadly, a lot of carcinoma cases will pass away very quickly, but it's very, very rare, very rare. But adenomas are fairly common. So tumor secreting ectopic ACTH, right? So small cell lung cancer or carcinoid or something else. So surgery or chemotherapy plus or minus a bilateral adrenalectomy. So it's buzzkill, right? Because I have to get rid of what's secreting the cortisol. So again, that's a little more complicated. Don't memorize that. Just understand surgery is definitely be indicated plus or minus the chemotherapy. And then, so we'll talk about this a little bit more, but like I said, we talked about it with a couple of different features that people are talking about. If I took out, for example, an adrenal adenoma, even though I still have another adrenal gland working, good job, it wasn't working the same way as when I was hypercortisolism. So sometimes you actually have to give the patient a little bit of steroids, kind of bring it back up to normal. And these slowly taper it off. And I would absolutely give ENDO phone call or internal medicine a phone call as far as what do you do now? But again, you're trying to get them to the right place. But they get developed or replaced in hypercortisolism needed temporarily. So I totally talked about when to refer, but please do more than just we get abnormal desmosis, suppression test. That's when I punt them out to endo. But it takes some time to get there. So you can definitely order the confirmatory testing. You can figure out where it was. You could definitely order the imaging. Just do it all in the right order. So again, untreated Cushing syndrome will be fatal. Because again, my cholesterol is going through the roof, so cardiovascular disease, stroke disease, that's sucky. Any one of those is going to kill a patient potentially. You have hyperglycemia, so diabetics can kill them as well. Diabetics is the same rate as a type 2 diabetic, is the same rate for having a heart attack as somebody who's already had a heart attack. So it's huge risk factors. So Cushing disease and adrenal adenoma have a great prognosis if you treat it surgically, right? The surgery, both options. One goes to your nose, one the back. Good job. Now, sadly, ectopic ACTH and adrenochromosome is crappy prognosis. You're not memorizing that whatsoever, but just understand, if I have a small cell lung tumor, we're secreting ACTH, because that's what it's secreting. Secreting ACTH, making my cortisol pop up and go crazy. That's also just a small cell lung cancer is a kind of a crappy prognosis as well. So that's all crappy. All right. Questions about that? Because we're going to stop there. Hopefully that's okay. Because I don't want to overrun your brains There we go. That's funny. Okay, so now we're going to talk about the opposite of this condition. For love of Christmas, do not confuse these two features. Cushing disease or Cushing syndrome does not at all look like Addison's. They present very differently. So don't look it up. Don't. So primary, what's my malfunction? If I say primary adrenal insufficiency, what's my malfunction? Exactly, adrenal gland. Good call. Also known as Addison disease, those two are synonymous. Reason this happens is a chronic deficiency of cortisol. Chronic deficiency of cortisol. So remember, the test you do if I think Cushing syndrome, I have too much cortisol, I give you a desmosin suppression test and see what happens to your cortisol. This is completely different test. Completely different test. I check your morning cortisol. That's the first thing I do. So, etiology, it's autoimmune in the United States. And a lot of developed countries, it's autoimmune. But some third world countries, it's more comes from a tuberculosis, sarcoidosis, some other funky conditions as well. But our most common is autoimmune adrenalitis, most common version in the States. So, one of the key things to remember is you must have atrophy, one of the words from lesson 1, atrophy of 90% of both adrenal cortices to have Addison's. So literally, it's like teeny, tiny, and it lasts both of them. So you have to have a big thing. One of the guys, I ended up, when I was in baby PA, I went to OBC, now it's called Bullock, and I knew it was deploying, in phase 2, because 9/11 happened when I was here. Yes, I'm that old. Also, we did take a test that day too. After 9/11. Yeah. Just deal with that. Reality test. Never forget. So I know. So that happened when I was here in PA school. Back was a year. And so everybody deployed in phase 2, and then I knew it was deploying right away. It was going to Germany and then straight to Iraq. And the only people who didn't do that were the people who, 4 people went to Korea. Only people didn't deploy in my class. But the guy who I was going to look to replace, he had Addison's. Can you imagine? This guy presents, I'll see you the signs and symptoms shortly. The signs and symptoms, he went to Kuwait and then drove up to Iraq, slow process. And he's look at some of the signs and symptoms, you're like, how does this guy survive? And he did, and so he ended up doing really crappy, and he got sent back to Lonsdale, was treated with steroids forever. That's the end result of that. But he had Addison's disease, and he ended up getting MEB for the military, so I'm telling you, it can happen. All I want to learn from this is the etiologies. If you have Addison's, you're much more likely to have another autoimmune condition. Or, for example, you could have Hashimoto's, you get Addison's. You could have diabetes mellitus type 1, that's the immune condition. Vitiligo, celiac, all these different versions. That's not all of them, but that's the ones you'll see, especially in endo. So to think he was tired, going up from Kuwait, driving up from Kuwait to Iraq, I think we were tired too. But some of his symptoms were kind of interesting. He was basically getting tan everywhere. But of course, everybody's getting tan everywhere. But even when he took his shirt off, he was still tan there, right? Because, Army uniform, look at this. So he was weak, fatigued, hyperpigmented, especially over the joints and palmar creases, or at the belt line, bra line, what have you. Especially in those features, more friction probably does that to you. Also, new scars would be darker than older scars. So I got, slash and whatever, that'll happen. So new scars, they get more hyperpigmented than that, especially in just coming on this. One of my former students, who Killed it in endo. Good job. He had a passion for medicine. He reached back to me on Facebook. I love Facebook. He reached out to me on Facebook and he was like, I had this patient who came in with her husband and he had seen GI a couple times. He was complaining of nausea, vomiting, belly pain, kind of some vague symptoms. Saw GI. Saw 2 different GI doctors. And she came with the husband and he's like, have you been doing a lot of sunshine? She's a Caucasian female. You a lot of sunshine? She's like, no, but I have noticed my moles look darker than normal. That's all I noticed. And then, like, literally looking at the husband and him, absolutely, my office badass PA diagnosed Addison's in a patient seeing GI, 2 GI physicians. But nausea, vomiting, and belly pain, anorexia, and weight loss. So, does that sound at all like a patient with Cushing's syndrome? No, it does not at all. So don't mess up how we go about testing it. So again, nausea, vomiting, belly pain, being all extra bronzy, weakness, fatigue, everywhere. And then anorexia and weight loss. Weight loss. So, good job. I'm stressing this because I've seen it by me before. Alright, so other things you'll have, especially the longer this condition is going on, the scalp, axilla, and pubic hair if you're looking there, right? So again, may have a good reason to look there, but the reason why is basically one of the things that's suppressed, not just cortisol, decreasing androgens. So I'm not making anything. So androgen, testosterone, estrogen, progesterone, all this stuff is getting decreased. So I'm losing my hair. And amenorrhea can also happen that as well. They get amenorrheic. Anxiety and irritability, that's actually a stat out of Current. 40% were told it was psychological. Don't be that PA. Be better than that. Alright. I thought this one interesting too. The salt craving can certainly happen. Again, a lot of that's because some of the downward side effects of this is you get basically hypernatremia. You're like wanting salt everywhere. The reason why is I have not enough aldosterone, so that's one of the side effects, and that's why I get the orthostatic hypotension. I don't have aldosterone, so I'm craving salt. Going buck wild. Alright, so I checked this before, but just put the slide in here again. Just ACTH, if I have too much of it, because I'm making cortisol, what's supposed to happen to ACTH? Let's go through the roof, right? Through the roof, it's gonna make it any more cortisol because I have atrophy of those glands. But the side effect of that is I make too much alpha-melanocyte stimulating hormone production anterior pituitary. So I get bronze skin. Bronze skin, that's what happens. So again, this is the potential for metabolic acidosis is probably the last thing if you miss this case. But again, most of the patients with this, fatigue, weakness, nausea, vomiting, hypotension. How does a patient with Cushing's syndrome present? Hypertension, exactly. This person with hypotension. And hyperkalemia, if you check their labs. So, what is this condition? Vitiligo, awesome. Yeah, so vitiligo, it's kind of a funky one. The vitiligo can happen. So I get more bronzing of the skin that's intact, but I can also have vitiligo. The key with vitiligo is it tends to be generally fairly symmetric. Not exactly symmetric, like a ring pinky there and pinky there, but that's an African male person who presents with white hands, right? So vitiligo. And it's not going to happen to everybody, but if you see that, it can certainly happen. But the pigmentation of his normal skin up here is darker than normal. And give some ideas of how you figure that out, especially in African American individuals. So would you just think this chick looks like tan a lot? No. So this is a good way of kind of looking in darkly pigmented people. So not just African American, but anybody who's darkly pigmented. So again, sometimes you'll see is like darkening of the nails. You see where the over these joints, those joints, the increase, and then you can have you see an increase in the gum line. So it shouldn't be dark like that, and the tongue should not be. It should be more like uniform, like pink color, and not that darkly pigmented color. Leaving you guys out. So that's that normal. You don't have to put anybody in that device. I encourage you not to do that, but yeah. It's an old picture, but still it's kind of decent. But again, they notice that the palmar creases are increased in the density. So this time wherever everyone looks at their hands, am I okay? No, they're good. So again, would you know this patient had Addison's? But if you listen to her signs and symptoms, she's having nausea, vomiting, belly pain. She's tired all the time. Figure it out. And she's also no ability to eat, and she's losing weight. Lost like 15 pounds on a frame that doesn't look like she needs to lose 15 pounds. So this is actually her. Yay! That's after. Yay! So the treatment options for her, we'll talk about this a little bit when we talk about treatment options, but the treatment for her was to give her steroids. I'm going to give you what you don't have anymore. Give them steroids. All right, so yay. And she got glasses. All right. I put the first, second, and third in this thing because they get kind of confusing if you look at this, but this is out of New American Journal of Medicine. So this guy had multiple other things. I think this is in your notes section, isn't it? I believe. Is it in notes section? Oh, perfect. I don't want to read it to you because it's a lot. But so anyway, so he presented as a first picture. But then he developed Addison's. That's his second picture, the one on the far left. The third picture, we got more normal. So kind of cool. All right. So the key labs, below Christmas, the key labs are low plasma cortisol. That's a starting test. Starting test. I don't give them any kind of desmosome because I don't think it had too much cortisol. I just give them plasma cortisol, and it's going to be low. Don't memorize the number, just it's low at 8 a.m. And then, how are you going to determine if it's primary versus secondary? We'll talk about secondary too. Primary versus secondary, you get the ACTH. 2 labs, same plasma, good to go. They get the ACTH, it's going to be crazy elevated. It makes sense because the patient's all bronze, but it's going to be crazy elevated. So this is the part, don't get confused. Trust but verify. You confirm it with something else. I think you learned this in pharmacology, I'm guessing. So this indicates primary function. This low plasma cortisol, elevated ACTH. You confirm it with the cosenterpin stimulation test. So there are some other labs you might see in this patient as well. So again, you don't have to check one lab. I always do CBC, CMP, TSH, because I like TSH on everybody, and lipid panel. That's kind of my standard test I do in every soul on earth. It's my patient. But these would be seen in all of those things. So here's the other lab abnormalities you'll see. So what is a cosenterpin? Also basically synthetic ACTH simulation test. So I inject an IM, and then I measure the cortisol levels after I injected that. I measure it after. Because what should normally, if I gave you synthetic ACTH, what should my cortisol levels do if everybody in this room, what would your cortisol levels do? Should go up. Exactly, should go up. In this case, because of atrophy of the adrenal glands, there's no cortisol coming out, not at all. So the level would remain the same. So that indicates primary adrenal insufficiency, the cortisol level will still be low. Right, so first test you do, check your low morning cortisol, 8 in the morning, good test, 8 in the morning, and their ACTH, so have a low plasma cortisol, elevate ACTH, trust but verify. I want you to confirm it with the cosentropin stimulation test, trust but verify. And then if I have Addison's, my cortisol level will still be effing low. Still going to be low, because give me synthetic ACTH is not going to do anything for my cortisol levels. Does that make sense? Cool. Secondary. Still want to keep going? I can't tell. Yeah, words. Okay. I'm going to. Because I can. Alright, so secondary adrenal insufficiency. We are the most common cause for secondary adrenal insufficiency. This is the reason why prior to the farm lecture you're doing now, it's so important that if you have a patient on anything more than like 5 days, you have to do a taper of those steroids. You have to do it, or you're going to kill them. You give them secondary adrenal insufficiency. Don't do it. So, inadequate secretion of ACTH by the pituitary gland. The most common cause for that is we give patients steroids. Let's say I gave you 50 milligrams of prednisone. Just trust me, that's a lot. Every day for 2 weeks, and you just stop it. What's going to happen to my body if I just stopped it and didn't taper it down? Exactly. I don't have time to make sure I have enough cortisol come back up. I'm relying on this 50 milligrams of prednisone, which is oodles and noodles, and then every day for 2 weeks, my adrenal glands are going to shut off. They're sleeping like, I'm good. You got this? Well, I'm asleep. So then I have trouble waking back up. If I stop it after like 14 days or a month, whatever that time frame is, basically my adrenal glands are shut off. So that's a huge problem. So I have secondary, which means coming from my pituitary, adrenal insufficiency. Does that make sense? Okay, cool. Just remember all the definitions. That is from the pituitary. So, other etiologies, anything involving the pituitary or otherwise. But most common, we did it to the patient. I stopped your medication, your steroids, abruptly, and that was a problem. We did it to the patient. Other ones that can go wrong with the pituitary, anyway, they can go wrong. Alright, so some features in this one. If I have secondary pituitary adrenal insufficiency, if I have this condition, I do not get hyperpigmentation. Why do I not have hyperpigmentation? Exactly, ACTH is low. It's low, because remember, ACTH is the reason why the bronze skin in primary. In this case, it's low. So melanocyte stimulation is also low, and they often refer to this as alabaster skin, like meaning a patient that's whiter than I am. Normally I'm more white than this, I'm somewhat mildly tan. But crazy, crazy white. Makes sense? Some of the other things. What are some of the labs we talked about if I have primary adrenal insufficiency? Primary adrenal insufficiency. So hyperkalemia, that's a big one that we'll have in this case. In this case, secondary adrenal insufficiency, you're going to have electrolyte levels are normal. They're normal. They're able to function normally. DHEA level is low. DHEA is like a proxy for ACTH, right? It's kind of thinking of it as being similar aspect. So DHEA level is low because the ACTH is low. So that's low, that's low. So understand, like I said, we're the most common cause for secondary adrenal insufficiency. Okay, so just go charts, can help you. So primary versus secondary, so we'll learn this and it's useful because it'll look vastly different. What would my skin look like if I had primary adrenal insufficiency? Bronze, exactly. What would it look like if I have secondary adrenal insufficiency? Pasty white, exactly. So in this case, hyperkalemia and hyponatremia. Remember, I'm salt craving. I want salt and everything. That's because I have hyponatremia. So that's the reason for it. Or, and this one, you have a secondary, you have normal electrolyte levels. By default, you have normal levels. So if I have primary adrenal insufficiency, one of the ways to go about diagnosing it, if I have low morning cortisol and I have elevated ACTH, so those two have to go together. And that's how you define whether it's primary or secondary. And this one, I have low or inappropriately normal ACTH, right? Low or inappropriately normal. So, trust and verify, especially with a patient with more vague symptoms. So again, not everybody presents all super bronze. So maybe if you had any concerns about this individual, so you trust and verify. So low cortisol level with ACTH stimulation. So that's my cosentropin test. Goes my muscle, one test, one time, measure my cortisol level, 4 or 5 minutes later, boom. It's still going to be low because my adrenal glands have atrophied. But if I have secondary to insufficiency, what's going to happen if I do the cosentropin stimulation test? Exactly. I got my cortisol levels to pop right back up. Right? 40 minutes later, pop right back up, and that gives you your answer to primary or secondary. So I first think the patient has adrenal insufficiency, kind of like my other good-o-us drawings. I do my best. So I think my patient has adrenal insufficiency. First step, check the morning cortisol level and your ACTH. I didn't add that, but ACTH. And then the second step is you do the cosentropin synthetic ACTH test. You measure the blood values level, measure cortisol again. And then, so if cortisol still remains low, that gives you your answer. You know you have primary adrenal insufficiency. Now, if my cortisol level is high, then I know I have a pituitary cause causing this to happen. Most common issue with that is, it's our fault. Remember, most common issue is secondary adrenal insufficiency. It's our fault. You abruptly, like some idiot, abruptly stopped your steroids and your body could not figure out how to kick it back into gear again. So meaning pituitary cause. There's other ones like traumas or stalk tumors and stuff like that. Don't worry about that, but we are the most common cause for secondary to happen. All right. So now going back between primary versus secondary, how to go about imaging this. We already kind of talked about this. For primary abdominal CT, you have small non-calcified adrenal glands, so basically atrophied. If we're working on deployment or somewhere third world country or something like that, certainly you're thinking some other condition, you could do this stuff. But what I want you to remember, abdominal CT or adrenal CT, either one is synonymous, is more focused. You got to remember to do the CT scan if you think it's primary. And then the small little non-calcified adrenal glands. So if you have to think secondary adrenal insufficiency, evaluate the medications. What I do wrong in this person? They have to have been taking something somewhat recently, within a week or two of this, have stopped it abruptly. So always getting past medical history is really important. And then how you go about evaluating that, look in the pituitary MRI, especially if they deny being on any medication. You got to look for what are the other causes that could happen in the pituitary. So pituitary MRI is your imaging of choice. Okay. All right, so I added this one about a year ago or so, the DHA replacement. this is how we're going to treat a person who has Addison disease. Note at the top, Addison disease, we're talking about different treatment options. So, the first thing you have to do is you have to replace the steroids. Have to replace the steroids. Do not memorize the timing of this, but understand you have to have more in the morning and less at night. More in the morning, less at night. Why is that? Diurnal, exactly. Now, so can't just take in the morning and then don't take it all at night. You have to take more in the morning and less at night. They also may require mineralocorticoid or aldosterone replacement. For anything other than the mildest of cases, you need flutocortisone, also known as Florinef. Because basically, I didn't just use cortisol. I also don't have aldosterone either. So that's the reason why you need both things, glucocorticoids and mineralocorticoids. So I added this one, like I said, about a year ago. I was talking to one of the students whose sister had Addison disease. And so she was saying, she's like, she's on a steroid for the rest of her life. Like, her life depends on this, whatever. But she's like, she just feels like often to like no energy. And she's like still severe fatigue, but the cortisol levels are as best as they're going to get. So I was looking at this. DHEA replacement, which is over the counter, you can also do it in the pharmacy, but DHEA replacement led to an improved sense of well-being, and also increased muscle mass and reduced rates of osteoporosis. Remember, again, all the negative effects of lack of cortisol. So before I used to only say glucocorticoid, mineralocorticoids, but this is actually in current now. Past couple of years, the DHEA replacement will certainly help this patient as well. So, improved sense of well-being sounds like a winner for me. I'm going to stop there. Any questions? Thanks for